if it's okay, we'll move on to Dr. Rasima Leroy from Trinity College. Dr. Leroy. Thank you, Dr. Dawes.
Thank you very much, Maureen. Thanks very much, and thanks for the invitation to speak here. So Piers has set up my talk very nicely, and I'll just take it one step further. Let me share my slides here. Whoops. There we go. Right. So I'm really focusing on trying to improve outcomes in people living with dementia through hearing rehabilitation and improving sensory health. So I think you've already heard us mention the SenseCog program. So much of the data that Piers and I use comes from a 5-year program that we've been leading, looking at the links among aging-related hearing, vision, and cognitive impairment across Europe. So in terms of the key research questions in sensory cognitive health, this is a very nice review paper that came out recently by Danielle Powell. And you can see that there are key areas in which we need to do a lot more work. First of all, understanding the mechanism, the discussion we've just had, but also looking at measurement, particularly with regards to looking at cognitive measurements and how best we can do this in the context of sensory loss. And then really the focus of my talk today is looking at treatment. Does amplification delay or prevent dementia? How best to intervene, and what other forms of treatment are there? So I'm a psychiatrist, I'm a geriatric psychiatrist. I work in a memory clinic. I look at people who present with cognitive difficulties and ask the question, is this a neurodegenerative disorder? Might this be Alzheimer's disease? Is this the beginning of dementia? Or are we already looking at a syndrome of dementia? And in a memory clinic, as you can see from this slide, a significant majority of people present with under or unidentified hearing problems. And for those who have a hearing problem, a very small proportion are wearing hearing aids. And again, of those prescribed hearing aids, a very small proportion use them correctly. So the issue of appropriately identifying hearing loss in the context of people with dementia is significant. And why is this important? So again, as a geriatric psychiatrist, I see this from the perspective of the person's experience living with dementia. And there is good data to suggest that people with unaddressed hearing loss in the context of dementia have more rapid cognitive and functional decline. So they do a lot worse, a lot faster. Secondly, challenging behavior, or what's also called neuropsychiatric symptoms of dementia, or behavioral and psychological symptoms of dementia, can often be exacerbated for people with unaddressed sensory loss. And this can lead to the increased use of antipsychotic medications or other chemical or even physical restraints. And that, of course, has significant implications in the context of dementia. We know the links with depression are there. There creates communication barriers, greater dependency, carer burnout, and the risk of premature institutionalization. So overall, I think the point made by Piers is that potentially, if we can intervene, this may be a relatively straightforward and cost-effective way of improving the lives of people with dementia to some extent. So the key question, does rehabilitation prevent dementia? In other words, or rather prevent the onset or the progression of neurodegenerative disorders? Now, this is the question that was addressed partly by Piers, looking at primary prevention. And it's the question really raised by that Lancet Commission. In other words, by addressing midlife hearing impairment, will that make a difference in terms of dementia rates later on? So I'm not going to go back to this question because ultimately we only really have epidemiological data to support this risk model. Instead, I'm going to move on to secondary prevention. So secondary prevention looks at whether a person already with the disease in their brain can have a slower progression. So here in the context of dementia, we talk about a pre-dementia stage, which is MCI or mild cognitive impairment. Now, keep in mind that this, of course, is not a disease process. This is the clinical syndrome resulting from multiple disease processes. So, for example, the majority of people who present with mild cognitive impairment may have the underlying disease of Alzheimer's disease, but not all will. So, can rehabilitation or intervening in terms of hearing loss slow progression to the full clinical syndrome of dementia? And just to clarify what I mean by dementia, dementia is the point at which your cognitive difficulties are significant enough to impact on your day-to-day life. and it's gradual and progressive and due to some kind of underlying cause. So in this case, people with mild cognitive impairment have some cognitive difficulties, but they can still function quite independently. So it's about preventing that progression. So how can you potentially intervene? Well, through hearing aid rehabilitation, through cochlear implants, through improving communication strategies, and so on. Now, what I'd like to tell you is that all of these types of interventions have been tried and tested and looked at in clinical trials, but that isn't actually the case. We're still at the beginning of this journey, but this is a critical question that we really need to address. So I'll just draw your attention to one study, which I think is influential, and that's the ACHIEVE study being run out of Baltimore through Frank Lynn's group. Now, an initial pilot study in 40 people with mild cognitive impairment, or MCI, showed that hearing handicap improved. However, of course, it wasn't powered to detect cognitive or functional changes. So this now has moved into a much larger, appropriately powered study with several hundred people to try to understand this question better. But again, we're still in the very early stages of this. So now I'm going to draw your attention to the work that I do, which is one step further. And this is about tertiary prevention in dementia. In other words, people with established dementia, can we improve outcomes or slow decline? So we first started looking at this question, and this is a nice review paper led by peers, to see what was out there, what kind of interventions for hearing and vision impairment to improve outcomes for people with dementia already exist. We started this effort in 2017, 2018, and as you can see from this slide, there were very few studies, 12 in hearing interventions, 5 in vision. Most of them were low to moderate quality, and there was only one high quality randomized control trial of a hearing aid intervention at the time. So clearly we had our work cut out and we had a lot more work to do. Of those studies, there were various hearing interventions, for example, hearing aids, active listening devices, communication strategies, hearing aid troubleshooting, and cochlear implantation. And the reason I'm mixing hearing and vision is because, of course, our population, our meaning people who work in the dementia world, are working with older people who almost always have dual rather than single sensory impairment. So it's very hard to tease these apart. So we were very keen to look at both hearing and vision interventions and loss. So to fill the research gap, we created a program called the SenseCog Intervention Development and Field Trial Program in preparation for a large-scale randomized trial. And there's a way to do this because this is what's called a complex intervention. In other words, it isn't a simple process of everybody getting exactly the same intervention, like the same drug, the same dose, for example. This is more complex than that. So we have to look at a number of different variables. So to develop this program and this intervention, we first had to look at people's needs. In other words, where were the gaps in what they were receiving in terms of care and so on. And so we did a support care needs study of older people across Europe to see what were the difficulties if they were living with dementia and single or dual sensory impairment. And we did a large-scale survey as well as some in-depth qualitative interviews. And this was guiding our intervention. So as you can see here, the themes that came out of this is, first of all, that anything that we needed to do had to be tailored to the individual. In other words, you couldn't take an off-the-shelf type of solution. It had to be tailored to that individual and their care partner. Secondly, it wasn't sufficient simply to provide a hearing aid or glasses, in other words, fixing the deficit. We also had to look at the wider picture, address care burden, social isolation, and loneliness. And this is the point that was made by peers as well, that these indirect pathways are key. A key element that also came out was the need for specific education around sensory aid. Again, not simply sufficient to simply give somebody a hearing aid, particularly if they've got dementia, and say, off you go and live your life. A lot of support, a lot of education, and working with a care partner is necessary. So we also looked at the literature, looking at what are the key factors that promote and improve adherence for hearing aids in older people. And this was the work done by our PhD student, Emma Hooper. And she did a recent systematic review of all these factors that are important for hearing aid adherence in people living with dementia in the community. So this isn't a care home population. This is people living in the community. And she did this around what's called the theoretical domains framework, which essentially is a way of trying to map out any sort of intervention in a behavioral sense, like giving a person hearing aids, to see what the key factors are and the barriers and facilitators. And she ranked the quality of the studies, including 12 studies using mixed methods. Now, I won't go through these in too much detail, but you can see the reference here in the slides. The key thing is that from the 27 summary findings, she had some key issues. First of all, a person's adherence with hearing aid is absolutely dependent on their skills. And their skills are about training and ensuring that the person with dementia and their care partner can use the hearing aids efficiently and correctly. Reinforcement was absolutely key. In other words, using the hearing aid, do you get a good feedback from it? Do you have good reinforcement? Likewise, the degree of fit and comfort. And these are fairly standard issues in the general population, but of course they are amplified in a person with dementia who is not used to new learning, who may find it difficult to change habits, to use new devices. The environmental context, of course, is important. And secondly, social influences. So I've just touched on that study. She did a lot of work, so it's very much worth your while taking a look at that and further. So putting all this information together, we created the SSI, or the Sensory Support Intervention, which had multiple components. First of all, it did involve a full hearing and vision assessment, which is fairly standard, of course. However, it's not standard in the sense that the majority of people with dementia don't actually get a full hearing or vision assessment. Therefore, it is something new and to be included as part of an intervention. Next, people were supplied with the appropriate devices, glasses or hearing aids. And then the critical piece was that they also had the support of an SST, or a sensory support therapist, to provide things such as adherence support, improving their sensory environment. Do they have the right lighting, acoustics, and so on? Communication training with the care partners, setting goals, and critically, social networking support. In other words, when you start developing dementia, your social network shrinks. Add to this the impact of hearing loss or vision loss, and that network shrinks even more. Those were the components. And how did we do it? This involved a weekly visit from the sensory therapist over a number of weeks. It was based in the home and supported by the care partner. So what we call a dyadic intervention. We field tested this to try to understand whether this type of intervention was feasible. And lo and behold, we came up with some very positive outcomes. I won't go through these in details, but essentially saying that this type of complex intervention was acceptable. It improved functional ability, reduced caregiver burden, increased self-efficacy, and improved socialization. We also looked at various quantitative outcomes like quality of life. This is the DEMQUAL, or the Dementia Quality of Life Scale. And what we showed that there was an important and minimally important clinical difference achieved from baseline to post-intervention in quality of life. So all of this was very encouraging, keeping in mind, of course, this was an open-label feasibility study. So it led us to go on to our full-scale randomized controlled trial, which we indeed did. And we conducted this across multiple sites in Europe and included many hundreds of people. And we had strict criteria for who would be included. So people with mild to moderate dementia, plus hearing and or vision impairment with a care partner living at home. Our primary outcome was quality of life, but we also looked at a range of different outcomes. And our quality of life, the key outcome was at 36 weeks. In other words, the intervention would last 12 weeks, and then we would see whether that made a difference at 36 weeks. But we also measured this at 18 weeks. So this is the trajectory of inclusion. As you can see right in the middle of the slide there, we had a big break there with lockdown, as all clinical trials did, and that was a bit of a challenge, but we did get there in the end. So what was our key finding? I'll go through these quite quickly. Essentially, what we found is that the majority of people here in the middle of the slide had hearing impairment. In other words, most had hearing impairment, either alone or mixed with vision impairment. We had only a small proportion of people, about 3%, who had vision impairment only. So this really suggests that hearing impairment was a key element here. Now, we looked at quality of life across different dimensions here, which I won't go through in detail, but essentially this is a fairly wraparound type of scale. And what we found was that at 36 weeks, we did not see improvement in overall quality of life, but we saw that the majority of people were prescribed hearing aids. So that really told us that people with mild to moderate dementia can tolerate and manage hearing aids quite well and were adherent. However, what we did find was that at 18 weeks, quality of life showed an improvement. So this was a very important finding. Now, we were in the midst of COVID, so it's quite difficult to interpret the findings of the 36-week, but clearly it was the message that providing sensory support in the context of devices is important in terms of the short-term quality of life. So now I'm almost at the end of my time, so I'm just going to make a quick point here to say that looking at people living with dementia in their home setting is absolutely critical, but also we need to look more closely at people in long-term care settings. And these are people with different care ecosystems around them and also with more advanced cognitive and potentially sensory impairment. So I won't give you any findings, really just to draw attention to the fact that this is a population we're starting to look at now, both in Ireland and in Australia, adapting our SenseCog intervention into this much more complex setting, which goes beyond addressing the individual, but also looking at care partner or caregiver, I should say, professional caregiver training, as well as the sensory environment of the entire care home, where people eat, socialize, communicate, and so on, but also the care system of care homes. In other words, how are they linked with their community providers for hearing aid or for hearing and vision health? So I'm going to stop there, and I hope that perhaps in next year we can come back and tell you about our long-term care findings. Thank you very much for your attention.
Thank you, Dr. Leroy. There's a couple questions that came through. First of all, in terms of this sensory support therapist, what kind of training is required for that?
Maureen, that's a very important question. So first of all, this is not an official role because it takes a lot of effort to create essentially a new professional role with its accredited training program. And in Europe, we've got very strict guidelines as to how that occurs. So we purposely designed the sensory support therapist as to be fairly agnostic to background and fairly basic in terms of the skills that they need. So we have people who were occupational therapists, some were psychologists, some were social workers, and we had one person who was a speech and language therapist. So any of those kind of therapy-based backgrounds within the health sciences would be appropriate for this role. And then a training package is put in to help them understand what sensory loss looks like in the context of dementia, but also how to manage aids and devices and support adherence.
So someone who works at a long-term care facility for people with dementia or memory issues, and often there's people who don't have a lot of high-level training or education as aides or assistants, so they really don't get this kind of training typically, right? And that's they're the ones who have most direct patient contact.
That's a slightly different issue. So with our home-based randomized control trial, we had a sensory therapist who was supporting, essentially a trainer for people with dementia and their care partners going into their homes. So they were the people who were trained at, a fair degree of specialism. In a care home, however, here you're pitching your training at a different group of people in a different way. And that's the point of our subsequent study within care homes, where we are providing training to frontline care workers. Actually, I should say 2 tiers of care workers. In other words, from the frontline care workers, understanding the basics of how hearing and vision impairment or loss manifests in people and how to support that and how to support the use of hearing aids and so on. But then from that group of people within a care home or a unit, 1 or 2 people would be selected as sensory champions and get slightly higher level training so that they would be the ones to actually be able to handle the hearing aids, support their use, change batteries, these kinds of things. So it's essentially a 2-tiered level, but they are frontline care workers, and that's different from a more specialized sensory support therapist.
Okay, and I have one last question. With all the information that's been disseminated and a lot of research studies as what you're doing and what the Lancet has promoted, if physicians, if we can get people who are elderly, whoever wants to define that age, to be, even when they're not showing problems with memory, but if their physicians would become more attuned to potential needs for hearing deficits, and maybe if they got their hearing tested more regularly, is that something that we hope that could help, that could make it easier as people maybe get dementia if they already have hearing aids before they have more memory issues, cognitive issues?
Maureen, that's an absolutely critical point, not only because of the potential of slowing progression, but also because if you end up needing a hearing aid, when trying to use and adapt to a hearing aid when you're already have developed dementia is much more difficult. And that's the same for any kind of new change or new adaptation. You want to do it as early as possible. So I think there's two elements to that. So you're absolutely right. So getting people, being attuned to screening for hearing and picking it up early, particularly if people are starting to have cognitive difficulties.
And, I know there's another question from the audience real quick. In terms of these factors for related to dementia and promoting the use of hearing technology, is there any thoughts in terms of what percentage that it could reduce dementia if this all went the way we would like it to go?
Key question. We absolutely don't have the data for that now. And we still haven't demonstrated that living with dementia or living without dementia, whether we actually can make an impact in terms of progression. In other words, and progression, do we find that by the symptoms and the functional ability or the actual underlying neuropathology? Mm-hmm. So important question for the future.
Thank you. Thank you very much. I appreciate that very much.